Hi everyone.
Hello, good afternoon, ma'am.
Good afternoon. So let's start the class.
Yeah, sure.
Is the screen visible?
Yes, ma'am.
Okay. So frozen embryo transfer. Let's deal with it. So first successful pregnancy following frozen embryo transfer was reported in 1983 by Trausen and Moore. Okay. So it's like a frozen embryo transfer. What does it mean? See, embryos are formed on third day or fifth day, okay, of the cycle after pickup. So once we make those embryos, then we have to freeze them if we don't want to do a fresh embryo transfer. So that is called a frozen embryo transfer cycle. Okay, basically those embryos are thawed again and then after making the endometrial lining, they are being transferred. So pregnancy rates following FET treatment are always lesser than following embryo transfer during fresh embryo transfer. Like this, it was said in H3 2006, but it is not like this. Now it's better. The FET improves the cumulative pregnancy rate and there's no risk of OHSS. And after pickup, pain is there to the patient. That is also not there. Also, psychological support is also there, as after pickup, patients get disheartened and very tired, so it gets relieved and then they can get an embryo transfer after 1.5 months. Known supraphysiological steroid levels are there, and the deleterious effects of cryopreservation can be negotiated by improving the endometrial receptivity. So preparing the endometrium, how does it prepare? Embryo implantation requires a receptive endometrium which needs synchronization between the embryonic and the endometrial development. So if there are 3 days embryos we are transferring, that is day 3. So we have to give progesterone for 3 days and then do an embryo transfer. Likewise, if fourth day embryo, then 4 days, fifth day embryo, then 5 days, and sixth day embryo, 6 days. Okay. So for FET, the age of the embryos after thawing needs to be synchronized to the age of the endometrium on the day of embryo transfer. Types of preparation. It is spontaneous ovulation cycles, natural cycles, and modified natural. Yeah. Abhinay, just one second. Okay. So types of preparation, spontaneous ovulatory cycles and stimulated cycles and hormone controlled cycle. Generally, which we do is hormone controlled cycles because in which it is easier to regulate. Okay. So then comes the indications of natural cycle. In ovulatory patients, frozen ET is successfully carried out after spontaneous ovulation. They can be done in young patients less than 35 years, regular cycles, ovulatory cycles. Natural cycle in that FET is cheaper as there is no need of injections, requires normal endogenous steroid hormone production. Identification of ovulation is very important in this. It can cause stress and anxiety because sometimes ovulation does not happen. Then we have to cancel the cycle. It is not the option when better control and flexibility in timing is desired. It cannot be used in patients with irregular cycles. Cancellation rates are high, as I told. And after 35 years, natural cycle fecundity is reduced. So it's better to do it in young people. Monitoring of natural cycle FET, it is done by baseline USG. Start monitoring on day 8 to day 10. Then on TVS, ultrasound is seen for endometrial lining, thickness, and dominant follicle. If dominant follicle is more than 14, monitor with LH urinary kit to see the LH surge. Okay, hormonal profile is optional. If you want to do, you can do to confirm ovulation. And then minimum ET for transfer is 7 mm. Once ovulation happens, with LH kit you are able to see, or with hormone levels or on ultrasound, then embryo transfer. For that, embryo transfer preparation is done. Principles are that ovulation occurs on the next day after LHP. E2 drop occurs on the day of ovulation. Absence of dominant follicle and fluid in POD are the evidence of immediate ovulation. HCG administration is considered as the day of LHP, modified natural cycle, it is called, when we give HCG administration. Otherwise, if we are not using HCG also, then it is a natural cycle. 3 to 5 days of progesterone exposure gives optimal endometrial receptivity. Natural cycle, FET, day 3 embryos can be thawed and transferred on the same day. Blastocyst, also, they can be thawed if they are day 5 and transferred on the same day. Natural cycle FET may luteal phase support is not generally required. However, if you have done a modified natural cycle or you have a history of failure, give progesterone support. And duration of progesterone support should be 84 days at least. Modified natural, as we discussed, that HCG is given. In the criteria for HCG administration is visualization of a leading follicle more than 17 mm in the diameter of by TVS, or serum estradiol concentration more than 150, or serum progesterone less than 1 nanogram. In patients undergoing natural cycle FET, triggering ovulation by HCG can significantly reduce the number of visits necessary for scheduling embryo transfer because there is no need of LH kit then. Okay. And ovulation triggering can increase both patient convenience and cycle, plus cost effectiveness is there. Stimulated cycles. Stimulated cycles, when we give clomiphene, adverse effects on the endometrium is there. Cervical mucus is also affected. So letrozole is being used. So letrozole, it has anti-estrogenic effect. CC plus HMG. HMG increases the E2 levels by producing more of androgen in early follicular phase. Stimulatory effect is there on endometrium and negotiates the deleterious effects of CC. So in that, what we follow is baseline scan on day 2 or day 3. Then serial USG monitoring from day 9. E2 optimum 150, which we just discussed. Then as the follicle leads to 17 to 20 mm, then around 5,000 to 10,000 HCG is administered. Day of HCG as considered as day of LHP. So transfer is along the same way. That day of HCG is considered day 0, and then either you give micronized progesterone or you give progesterone injections for the priming of the endometrium. Stimulated FET cycles, risk of OHSS is there, so sometimes they need to be cancelled. Cost factor, obviously, when HMG injections are being used, need for monitoring, but it can be used for irregular cycle patients. Precise timing of HCG required 17 to 20 mm. Prolonged dual hormonal treatment not required if patient becomes pregnant. Hormonally manipulated cycles are either down-regulated cycles followed by HRT, which are commonly being used in endometriosis patients. Because endometriosis patients, we generally do by giving a GnRH depot of 3.75 mg on day 21 with the OCPs, and then the next cycle when period comes, then day 2 we start the HRT. That is called a down-regulated cycle. It is indicated in functionally intact ovaries, anovulatory or irregularly ovulating cycles. And if programming needed, we can avoid weekends because this is helpful in batch IVF cases. In that which is fixed, like embryologist and doctor will only go on fixed dates. Down-regulated cycle advantages are it simplifies the synchronization between the embryo and the endometrial development. Example in an anovulation irregular cycles, minimizes the chance for premature LH surge. It decreases the need for USG and endocrine monitoring. Cancellation rate decreases. More controlled transfer timing. Down-regulated cycles disadvantages, hypoestrogenic stage, cyst formation may be there, prolonged treatment because it starts way before the cycle, like on day 21 we have to give the injection and 21 days of OCP is there. Okay. Plus sometimes people are not giving depot and they are giving daily administration of injections like 0.2 milligram of Lupride. The need for maintaining daily exogenous dual hormone replacement throughout first trimester in pregnancy is there. In GnRH administration, GnRH started after 2 weeks of oral contraceptives with a 5-day overlap of GnRH agonist and oral contraceptives, which I told you, which can either be given on day 21 as 0.2 to 0.5 or 1 milligram subcutaneous daily till day 2, or on day 21 you can give a depot injection. Okay. Then day 2 you can confirm the pituitary downregulation by doing estradiol and progesterone levels. And once downregulated, dose of GnRH agonist is made half or same dose, continue till the progesterone administration. Day 2 hormonal administration is needed in this. Hormonal administration, E2 orally, vaginally, transdermally or intramuscularly. Progesterone vaginally, intramuscularly. E2 administration, variable low dose step-up regime. Progenova 2 milligram, Progenova 2 milligram BD, then TID. So maximum dose is 16 milligram, which can be given in any cycle. If more than 7 mm, continue till day 14. And then day 15, you can start the micronized progesterone. E2 administration, minimum days of E2 exposure required for attaining endometrial receptivity is 7 days. Maximum is 35 days. But we are generally following 14 to 15 days. So progesterone administration started on day 15. Micronized progesterone 200 milligram TID or 50 milligram OD. Continued till pregnancy test. If positive for pregnancy, continue till 84 days post ED. सारी मेडिसिन खाएंगे. तो इसको एक पत्ता दे दो, सुबह दोपहर शाम खाएंगे. ठीक है. एक ही पत्ता बस. हाँ, वो तो एक ही पत्ता दे दो. Best route for hormone administration. The best route of administration is basically unclear, but we are using vaginal or injections. Embryo transfer, which like I told you, like day 2 embryos, you have to thaw warm on day 17. Same day or next day transfer. Day 3 embryos, we have to thaw that day, or we can do if day 2 embryos are frozen, we have to thaw them one day before. It seems to be appropriate to start progesterone before ET in oocyte donation cycles as FET and soon as the endometrium develops sufficiently, that is 8 mm with trilaminar pattern. The embryo transfer is performed after at least 3 days of progesterone treatment for day 3 embryos. Non-down-regulated HRT cycles. These are hormonally manipulated, in which down-regulation is not necessary. Okay, there's less frequent monitoring, cancellation rates is less, good control and flexibility is there. In this, administration of steroids are similar to down-regulated cycle. To suppress ovulation, we start estradiol on second day or third day. Okay. Hormonally manipulated cycles, E2 protocols, high dose fixed regime, low variable dose step up regime. Low variable dose step up regime gives more physiological estrogen stimulation of endometrium that mimics the hormonal pattern of spontaneous cycle and more suitable for endometrial development. Hormonally manipulated cycles, an adequate period of estrogen administration is necessary in order to achieve a subsequent normal secretory endometrium. An optimal endometrial proliferation is necessary for the optimal development of progesterone receptors and subsequent transformation into a receptive endometrium. Role of E2 levels in hormonally manipulated cycles. The thickness of endometrium has no relationship with E2 concentration. A wide range of E2 level is compatible for the establishment of clinical pregnancy. The endometrial thickness between 7 and 15 mm and estradiol serum level did not relate to significantly different pregnancy rate. This was being told by Banz et al. So basically, it should be more than 7 mm but less than 15. But generally, for practical purposes, it should be 8 to 9 mm. Okay. FET evidences that significant effect it is seen in patient age and number and quality of embryos replaced. It has a major role. Okay. No significant effect of the duration of storage of embryos, endometrial preparation type, and cause of infertility. It can be primary or secondary both. The synthetic hormone protocol was associated with a higher live birth rate when compared with the natural cycle protocol for the frozen thawed blastocyst stage ET cycles. This improvement persisted when analysis was controlled for cycle cancellation also. The synthetic stimulation protocol for frozen thawed cycles offers improved outcome results for the patients. Types of protocol for COH and FET, it is generally independent of the GnRH analog and final oocyte maturation oocyte in the collection cycle. Lower IVF embryo transfer success using GnRH antagonist, GnRH agonist protocol does not appear to be related to an adverse effect on oocyte quality. FET Cochrane review. It is found that no evidence to support one protocol over the another. Okay, although a higher live birth rate was found in synthetic protocols that uses GnRH agonist versus those that use estrogen progesterone only. Okay, but GnRH agonist using is very cumbersome and costly. So we generally use estrogen progesterones only. Role of zona thinning. The results of the investigation show that laser zona thinning may have an unexpected adverse effects on the rates of clinical pregnancy implantation. Generally, laser hatching is done in patients who have previous history of failures or they are advanced maternal age, like 35 years above. Conclusions: endometrial preparation is cheaper with natural cycles. It cannot be used in menstrual irregularity. It is not a suitable choice when better control and flexibility in timing is desired. The need for precise determination of ovulation time may lead to anxiety. Cancellation rate is high. In natural cycles, increased age decreases fecundity. It should only be done in younger cases. Patients with irregular anovulatory cycles with functioning ovary can be managed with hormonally manipulated cycles with or without GnRH agonist. Both strategies are equally efficacious, without GnRH agonist being more simple and patient-friendly. Cancellation rates for hormonally manipulated cycles is 2% only. Otherwise, with downregulated, 0%. Okay, thank you. Any questions, please? Yeah, tell me. Hello.
Madam, on day 21, if we give GnRH analog,
Okay.
Are we sure that periods will be expected as on the 30th day or 20th?
Yes. It will come.
It will come. Okay. And from that day onwards, suppose we want to put estrogen and progesterone, we start Premarin.
Yes.
From which day we start Premarin, madam?
You have to start OCP pills from day 5 to day 25 of the cycle in which you are giving GnRH agonist.
Okay. Day 5 to 25. And day
Yes.
21, we give GnRH and
Yes.
agonist so that we get the periods. And
Yes.
from which day of this thing we start estrogen and progesterone?
Day 2. Day 2 or day 3.
Day 2 or day 3. We start Premarin 0.625 mg.
Yeah, you can. Yes.
Or Proginova. Which one is preferred, madam?
Proginova is the best.
Proginova. 2 mg TID.
Yeah.
2 mg TID. Okay.
Yeah.
And which day we are going to add progesterone?
You will add on day 15, day 14 or day 15, depending on your endometrial lining. Like till day 14, day 15, your target should be that it should reach by 8 mm.
Okay. So once we add progesterone, then which progesterone is preferred, madam?
2 मिनट में सुन रही हूँ आपकी बात. हाँ बताइए. Yes, tell me.
Madam, progesterone, which one you prefer, madam?
Progesterone, generally I give vaginal progesterone.
Vaginal. Okay. 400 mg TID.
Yes.
Okay. Then embryo transfer will be when depending upon the endometrial thickness, at least 8 mm.
Yes, at least 8 mm.
Okay. Okay, madam. Thank you.
Okay.